Welcome back to the Talking Ketamine podcast. This is episode 63, Ketamine's Hidden Interactions, a transplant patient story.
Ever wonder how medications can surprise us with unexpected interactions? Today we're exploring a fascinating case where ketamine, used for pain relief, seemed to change how a patient's transplant meds were working, highlighting the need for careful monitoring.
Imagine you're reading this medical report, right? And you see a patient who survived a heart transplant, only to realize that the pain medication meant to, well, heal him, is actively teaching his liver to destroy his anti-rejection drugs.
Yeah, it's a completely wild scenario.
It really is. It takes us into this highly volatile web of drug interactions because we're looking at a standard pain intervention that nearly unraveled the foundational therapy, keeping this guy's new heart viable.
Right, and to really grasp why this interaction is so critical, you have to understand the tightrope that transplant patients walk every single day.
Oh, absolutely. It's an incredibly delicate balance.
It is. I mean, you have these foundational medications for solid organ transplants, right? Specifically immunosuppressants like tacrolimus and sirolimus.
Heavy hitters.
Exactly. And their vital role is to suppress the immune system just enough to prevent the body from rejecting the new organ.
Right, but I always like to picture it for you guys listening as balancing a scale. If the scale tips one way, meaning there's too little medication, your body literally rejects the vital organ.
Which is obviously the worst case scenario.
Right. But then, if it tips the other way and you have too much medication, you suffer these incredibly toxic side effects. It's a razor-thin margin.
It really is. And the context here that's so important is that both of these drugs, tacrolimus and sirolimus, they're primarily metabolized in the liver by these very specific enzymes called CYP3A4.
Okay, CYP3A4.
Yeah. And because their target range is so narrow, literally anything that messes with those liver enzymes is just a massive red flag.
Which brings us to the collision in this 2026 case report. Because, you've got this scale perfectly balanced, and then an inciting incident just threatens to knock the whole thing over.
Yeah, let's look at the patient. He's a 55-year-old man, and he is 16 months post-heart transplant.
So he's been stable for a while.
He has. But then the sudden crisis hits. He develops a severe, deep vein thrombosis, a major blood clot in his left leg.
Oh, wow.
Yeah, it's bad enough that it requires a surgical thrombectomy and a stent to fix it.
And I imagine the recovery from that is just brutal.
It is. Post-surgery, his pain is excruciating. He's reporting an 8 or 9 out of 10, and that's despite being on, really heavy painkillers like tapentadol and morphine.
Which just aren't cutting it.
Not at all. So the doctors, they have to pivot. They initiate a low-dose, continuous subcutaneous ketamine infusion to manage this acute pain.
Right. They start at 5.2 milligrams an hour, and bump it up to 10.4.
Exactly. Just a steady, continuous drip to get the pain under control.
Okay, but I have to play patient advocate here for a second. Wait. Ketamine is an anesthetic, right? It's a pain reliever targeting the nervous system.
Yeah.
Why would we even suspect that a drug acting on the nervous system would have anything to do with a heart transplant medication in the liver?
That is the exact question, right? It seems so unrelated. But here is what happened next. They ran routine blood tests, and they saw that the patient's immunosuppressant levels had just suddenly plummeted.
Completely dropped off.
Yeah, way below the target range. The ketamine had basically thrown that scale totally off balance.
So now the doctors are facing this terrifying crisis. I mean, the leg pain is managed, sure, but the heart is suddenly at real risk of rejection.
Right, his immune system is waking up.
Exactly. So they have to take these desperate countermeasures, which blows my mind. They drastically increase the immunosuppressants. They bump up the tacrolimus by 1.8-fold.
Which is a big jump on its own.
It is. But then the sirolimus, they increase that by an incredible 5-fold. 5 times the dose.
Yeah, you would think that would flood his system.
Right, but despite this massive influx of medication, the blood concentrations barely moved.
It's crazy.
It's like, imagine you have a leaky bucket, and the doctors are pouring 5 times as much water to this bucket, but the hole at the bottom has suddenly grown twice as large. So it just keeps draining out as fast as they pour it in.
That is a perfect way to visualize it, because what was happening, pharmacokinetically speaking, is that the ketamine actually revved up those liver enzymes.
The CYP3A4 enzyme.
Yes, exactly. It induced the liver to clear out the tacrolimus and the sirolimus about twice as fast as normal.
Wow, so it wasn't blocking the drugs. It was literally making the liver destroy them faster.
Exactly. It's called enzyme induction. And the peak clearance, the maximum speed of this destruction, it happened about 1 week after the ketamine was started.
Okay, but there is a slight curveball here, right? A confounding factor we have to mention.
Yeah, there usually is in these complex cases. The patient briefly took an antibiotic called flucloxacillin for a suspected wound infection.
And that matters because
Because flucloxacillin is actually a known, albeit weak, inducer of these exact same enzymes.
So wait, how do they know it was the ketamine and not the antibiotic?
Great question. They use something called the Drug Interaction Probability Scale, or DIPS. And the DIPS score came back as a +5, meaning the ketamine was highly probable to be the primary culprit, mostly based on the timeline.
Right, because the timeline of the ketamine infusion perfectly matched that 1 week peak clearance we talked about.
Exactly. The antibiotic exposure was just too brief to cause that massive of an effect.
Got it. Okay, so we're at day 15, and they finally stopped the ketamine infusion. The leg is better, the pain is down,
Right.
but the story isn't over. Because, how does the body recover from this enzyme overdrive?
Well, it's a slow process. That's the scariest part, the lag time.
The lag time, right?
Yeah, turning off the ketamine doesn't instantly fix the liver enzymes. It's not like a light switch. It takes about 3 weeks for those extra induced enzymes to degrade and return to baseline.
3 weeks where the liver is still hyperactive.
Yes, and that sets up a massive rebound effect.
Because remember, the doctors had cranked up the dosages like 5 times normal just to keep the bucket full.
Exactly. So the week after stopping ketamine, the drug levels in the patient's blood progressively spiked. The liver was slowing down its processing, but the huge doses were still coming in.
So the bucket is suddenly overflowing.
Violently overflowing. The tacrolimus doubled by day 36, even without them changing the dose.
That is terrifying.
It is. And it caused a temporary spike in serum creatinine, which basically indicates severe kidney stress. The kidneys were taking a beating until the doctors could rapidly lower the doses again.
It's like tweaking a recipe,
Mhm.
You can't just blindly follow the standard recipe instructions when your oven temperature keeps wildly fluctuating. You have to constantly taste it, test it, adjust it. It just emphasizes how incredibly important it is for you as a patient to ask your doctors about drug interactions anytime a new medication is introduced.
I completely agree. And the ultimate takeaway here for clinicians and patients is clear. If ketamine is used for patients on these narrow therapeutic range drugs,
Like the transplant meds.
right, extreme vigilance and increased therapeutic drug monitoring are required. And not just during the ketamine infusion.
But for a full 3 weeks after it stops.
Exactly. You have to monitor them through that entire washout period.
So even a medication like ketamine, often used for pain, can have surprising effects on other vital treatments. It highlights how important it is to be your own advocate and stay informed.
Indeed, this case underscores the need for clinicians to exercise caution and closely monitor drug levels when using ketamine in patients on CYP3A4 metabolized immunosuppressants, even after ketamine is discontinued.
Always good to know. Thanks for listening to the Talking Ketamine podcast. We'll catch you on the next one.